Uh, Good morning, everyone. Thank you for your kind presentation, and thank you to Professor Shaltu and all the organizing committee for inviting me to this wonderful conference. Unfortunately, I could not be with you physically, but I'm with you virtually, and I hope to follow till the end of the conference. And I hope that for the next year you will invite me again, and probably I'll come to visit again Cairo. So these are some figures from the IDF Atlas for the night for the 2017 with more than 425 million people with diabetes. Now there are more than 450 million people with diabetes in the world, and in the United States there are more than 30 million people living with diabetes, with at least 1.5 million new diabetes cases diagnosed each year. We can see a continuous increase in diabetes prevalence all over the world, but more significant in the East Asian region and Africa. We can see that for the last 30 years, it has been a six-fold increase in the new cases of diabetes and diabetes prevalence in African region, five-fold more increase in Southeast Asia region, and four-fold more cases with diabetes in the world compared with 1980s. And there is a close relation between the increase in type 2 diabetes and obesity during the year. This is why they have a close connection, and more higher is the BMI, much higher is the risk for having diabetes. For example, for the women with the BMI of more than 35, the risk for having diabetes is 93-fold increase, and for men with BMI of more than 35, there is a 42-fold increase for the risk of diabetes. But obesity is not related only with diabetes, but it's related with an increased risk for mortality and 2 to 3-fold increased risk of death. Again, today we don't speak about obesity and diabetes, but we speak about diabetes, which is strongly related between obesity and type 2 diabetes. On the other hand, if we decrease our weight, we can decrease the cases of diabetes or the risk for diabetes and increasing the insulin sensitivity. What makes diabetes more dangerous are the complications of hyperglycemia, leading cause of blindness, leading cause of renal failure. More than 60% of the amputation occur in diabetes patients, and there is a significant risk factor in birth defects and miscarriage. Everything in life is balanced. Our organism needs it too. We need a balance between the food that we take, so the calories, and the physical activity for expending these calories. And today we are living in an obesogenic world. What are the main causes of obesity today? First of all, is the increase in sedentary lifestyle and sedentary behavior. On the other hand, there is a big change in our eating habits. For example, in the United States, it has been an increase of 40-fold in the increase of the sugar intake on the last century. And in only 30 years, it has increased in more than 60 liters per year the intake from the refined grain. On the other hand, there is a continuous increase in the calorie intake of people. In the United States, for example, women are eating 335 more calories per day, and men are eating 168 more calories per day every day. And one of the reasons is the increase of the portion size. For example, we can see that in the last 30 years, it has been an increase of 50% in calories in the hamburger and tenfold more calories in the French fry portion size and popcorn. And what is more important is that this kind of junky food is very uh, possible, and uh, all the people have access to it, even the people with low income. And this is the most dangerous thing to have for the future, because for more than 2 million years the mankind has evaluated, becoming the human intelligence of today, but we lost in the last 50 years this physical activity, and so we have the obese mankind, and in the we are living now also in the sedentary lifestyle. So this is the risk for today and for the years to come, and it is associated with the increase in insulin resistance. In this case, the patient needs more insulin to achieve the same blood glucose lowering, but on the other hand, the insulin resistance increases the risk for having diabetes and other macrovascular complications. And it is closely associated with obesity, especially visceral obesity. How we can prevent or fight the insulin resistance? Losing body fat, increasing the level of activity, having a good blood glucose control, managing the stress, having necessary hours of sleep, not less than 6 hours per day, and a good choice of food, reducing the carbohydrate intake in general. We are all familiar, so I am not staying very long to repeat what we say for the healthy diet in general, but which is important, the idea of the half of the plate with vegetables and less sugar intake and fat intake. On the other hand, what is very important is the increasing on physical activity. For children with diabetes or prediabetes, at least 60 minutes of physical activity every day. And for adults with diabetes or prediabetes, 150 minutes per week of moderate intensity aerobic physical activity every 2 or 3 days, with no more than 2 consecutive days without exercise. And adults with type 2 diabetes, at least twice weekly resistance training. Sitting is the new smoking. So we are living in a sedentary world, and we need to fight against it. Something about type 2 diabetes reversal. For the long time, type 2 diabetes has been identified as an incurable chronic disease, and the best outcome has been to expect an amelioration in symptoms or slowing its inevitable progression. About 50% of type 2 diabetes will need insulin therapy within 10 years of diagnosis. But in the global report on diabetes of the WHO, it was added a section on diabetes reversal and acknowledged that it can be achieved through weight loss and calorie restriction. Diabetes reversal is a term that has found its way into scientific articles and other names such as remission. While the exact criteria are still debated, a glycated hemoglobin under the diabetes threshold of 6.5 for an extended period of time without the use of glycemic control would qualify as it. And how long could be this period of time? At least 12 months without medication. On 2014, in Kaiser Permanente, the diabetes remission rate was found in 0.23% of standard care, but a significant number of studies indicate that diabetes reversal is possible using bariatric surgery, but also other approaches as it is low-calorie diet or carbohydrate restriction have shown effectiveness. In 2003, the Look Ahead trial randomized more than 5,000 overweight or obese patients with type 2 diabetes to an interventional group that received either an intensive lifestyle intervention or diabetes support and education. And we can see that with the changes in lifestyle, there was much higher decrease in the weight from the initial rate, especially in the first year, but even during the 8 years of continuation of the study, there was a significant difference between the intervention group and the educated, let's say, or the control study group. The 8-year weight loss, it was very important, and it could be achieved more than 50% of the weight loss from the initial weight. And it is continuously in the whole groups and for the 8 years of the study. That's why on 2019 in ADA Standards of Care, for the first time it was mentioned that with very low carbohydrate eating patterns has shown to reduce glycated hemoglobin and the need for anti-hyperglycemic medication. These patterns does not appear to increase overall cardiovascular risk. In another study on 2003, it was a study made in South Korea with 92 patients with type 2 diabetes of long diabetes duration. It has been treated intensively with insulin therapy, and overall 34% of the patients went into remission that lasted an average of 14 months after about 2 months of intensive insulin therapy using an insulin pump. So, remission rates were higher when patients started intensive insulin therapy with a shorter diabetes duration, 3.3 years versus 9 for the non-responsive group, and the non-remission was less important in this duration of diabetes. Direct study is another study which is a little bit different from the other because it was created and put in practice in a primary care setting in UK. We can see that in general the recruited population of about 300 type 2 diabetic patients with obesity were males with a high percentage of depression, with a BMI of about 35, of the age of 54 years old, and a short diabetes duration of less than 3 years. There was no difference between the intervention and control groups, with about 75 to 77% of them on medication, and the bad metabolic control of the glycated hemoglobin. The primary outcome was the loss of more than 15 kilos from the initial weight and improvement on glycated hemoglobin. We can see that in 12 months, about 46% of the patients were in remission, and it has decreased a little bit during the second year of the study, but more than 36 patients, even after 2 years, were in remission compared to the control group. The remission was more likely with greater weight loss from the baseline and with a continuous weight loss during the 12 to 24 months of the study. The remission was slightly more likely with older age and for the male sex. But what is important is that the people that lose more than 10 years during the whole study, 64% of them were in remission even after 24 months starting of the study, and the most important weight loss was in the first 12 months with more than 15 kilos, and from them, 32% of these patients continued to be on remission. There were other secondary positive outcomes, such as the decrease in systolic blood pressures or the number of antihypertensive treatments, decrease in triglycerides, an increase in quality of life, and less adverse events. 36% of intervention participants had sustained remission at 24 months. The glycated hemoglobin has significantly reduced in the intervention group, with 50% of participants reducing the use of medication, and durable remission of short duration of type 2 diabetes is attainable in a primary care setting. 70% of patients were in remission from them that lose more than 15 kilos during the study, and with a weight loss of more than 10 kilos, there was a maintaining of weight loss, and early remission should be a primary management target for type 2 diabetes. And this is one of the cases that participated in the study. Before the study, 24 years with diabetes, type 2 diabetes, and taking about 300 units of insulin per day with continuous care. The glycated hemoglobin has been dropped to in 1.4% of insulin, blood pressure down of treatment for blood hypertension, lost more than 70 pounds during the study, and has a complete restored metabolic health. And we can see these two pictures. We cannot imagine that it is the same person in only 2 or 3 years or follow-up. What about the reversal of type 1 diabetes? Is it possible? There are some studies and some treatments now that are giving hope for people with type 1 diabetes, as it is the case with some of the clones used in the treatment of type 1 diabetes of short duration, or some medicaments such as this rituximab or abalacept that gives hope for people with type 1 diabetes, as it is, for example, the case with teplizumab, showing that the people having the treatment are preventing or delaying the diagnosis of type 1 diabetes. But what we are more interested today is to speak about the remission in type 2 diabetes. And now it is clear that type 2 diabetes is a simple condition of fat excess, not only that, but in general, to which some people are more susceptible than others. And with health motivated people, they can reverse their type 2 diabetes completely. More we lose weight, more we have improvement in general health condition, and we can, for example, with the 10% of initial weight loss, we can have an improvement in apnea and a very good quality of life. But what is more important, we can have a high remission rate. But we are living in an age of obesity with inactive lifestyle, poor nutrition, and calorie imbalance that threatens the longevity of humankind. That's why bariatric surgery is another possibility, with a great reduction in glycated hemoglobin in people with diabetes, and what is more important, with a weight reduction in 2 or more years. Bariatric surgery is the most effective method for overall efficacy and prolonged remission for type 2 diabetes, but this treatment, cost, and complete lifestyle medication after surgery remain challenges for wide adoption. We know that the weight regulation and our food habits are related to a lot of uh, signals from the brain and hypothalamus, and also related with a very huge number of hormones. Before we were talking only about insulin. Later on, we began talk about leptin and adiponectin, and now we are talking about ghrelin, and also GLP-1 and GIP are in the list of the possible and uh, uh, future development in the field of preventing obesity and type 2 diabetes. Bariatric surgery still is the most effective treatment for sustained weight loss. There is criteria to qualify for it. The age from 16 in some countries is from 25 to 65 years old. BMI of more than 40, but we can talk about it and we can introduce the bariatric surgery even for people with BMI of more than 35 that have serious comorbidities such as type 1 diabetes. Uh, There are several kinds of intervention, from the most simple one and less invasive, such as adjustable gastric band, and going with a very complicated intervention that reduce the surface of the stomach or the gut, such as roux-en-y gastric or vertical slit gastrectomy. And there is a very important weight reduction from the initial weight from 46% with band restriction to more than 63% with biliopancreatic diversion. And we can see that there is a resolution or reversal of diabetes of more than 56% in the gastric band, going to more than 95% in the cases of biliopancreatic diversion. These kind of interventions decrease appetite and increase the early satiety, so no more hunger, and in this case, the weight is reduced. After metabolic surgery, there is an improvement in glycemic control, and diabetes remission can occur almost immediately in the first 6 months after the intervention. For this reason, the IDF has published a statement for type 2 diabetes where it is noted that surgery is accepted option in people with type 2 diabetes and BMI of more than 35. Procedures must be performed within accepted guidelines, and it requires comprehensive approach and ongoing multidisciplinary care, patient education, and follow-up. You can see some cases that have lost more than 40 kilos in the 18 months or after the surgery, or even after 5 months after the intervention. And I wanted to mention something about new treatment on prevention of diabetes or the treatment of obesity and type 2 diabetes. We are all familiar with GLP-1 agonists, but what I wanted to mention is tirzepatide, a novel dual GIP and GLP-1 receptor agonist that it is associated with a weight reduction in several studies, such as this SURPASS-2, where the decrease in the weight from the initial has been more important in the group treated with 15 milligrams per week of tirzepatide compared to only 6 kilo of weight in 40 weeks with the treatment of semaglutide 1 milligram per week. So in summary, we can say that type 2 diabetes is reversible, and does it will come back? No, if we provide to weight the same weight and physical activity for a long period of time. We need to choose the appropriate therapy, comparing the side effects, the cost, and what is important, extraglycemic effect. And we can see that with the weight reduction, we can have a remission on diabetes, but also an improvement in general health. And what we say today, it's all about prevention. So it's better to prevent diabetes, but if we have diabetes and obesity, it's better to start early its treatment, and what is more important, with the weight loss. So what I wanted to mention is that we need to stop to pass from here to here, but now we have the remedies to pass even from here back to the normal weight for people with diabetes and the general population. Thank you very much for your invitation.